so that you have that. So I do want to read a statement before we get started from our compliance department. The content is not intended to be medical advice, and the viewers should consult their physician should they have any questions. Viewers should not only rely on information contained in this webinar for urgent medical needs. Additionally, if you think you may have a medical emergency, call your physician, go to the nearest emergency department, or call 911 immediately. Never disregard professional medical advice or delay seeking care because of the information contained in this webinar. Again, our session is entitled Ductal Carcinoma in Situ, or DCIS, and Dr. Hansen will be presenting. Born in 1990 in Caracas, Venezuela, he pursued his passion for medicine by attending the Universidad Central de Venezuela. I hope I said that correct, Dr. Hansen. Following Dr. Hansen's academic journey, he also completed general surgery residency at Bronx Care Health System, where he honed his skills and the dedication to healthcare. Besides his medical pursuits, he is an avid soccer enthusiast and enjoys engaging in various outdoor sports. He is deeply committed to improving healthcare for minority patients, striving for an equitable and accessible medical care for all. So Dr. Hansen, we'll go ahead and turn it over to you, and you can start sharing a screen.
Thank you for that introduction, Carol. Let me see. See if I can just move this around. Places. There you go. Okay, you see my slides?
I do not.
You do not. Let me see. 1 second.
There we go.
How about now?
Yes, can see them.
You can't?
Yes, we can see them.
Okay, perfect. All right, so we're going to talk today about ductal carcinoma in situ. So what is ductal carcinoma in situ? So there's two different, cancers that can develop in the breast. You're going to have the lobular segments, which basically produce the milk, and then the ducts that basically bring the milk from the lobule to the nipple. So ductal carcinoma in situ, number one, is the most common type of non-invasive cancer. If you see a cross section of the duct, like I'm showing here, you can see that normally the duct will have cells lining the inside of the duct. And when those cells start reproducing a little bit, it's called hyperplasia. That sort of like tells us that there's something funky going on, but there's no cancer yet. And when it starts occluding the duct like this is called, it's more like this, but it's occluding the duct and it's not going outside. That's called DCIS or ductal carcinoma in situ. In situ means that it's staying in place and it's not going outside of the duct. So it's the most common type of non-invasive cancer. It has not left the lactiferous duct. It's pre-invasive. It's not invasive yet. That's what we call a stage 0. And about 63,000 women are diagnosed each year in the United States. So as I was saying, this is the lining of a normal duct here. This is when cells start dividing or replicating a little bit, but they still look kind of normal. It's called hyperplasia. And when they start looking funky, it's called atypical hyperplasia. And when they fill the entire duct like this is when we call it in situ. And when they start coming out of the duct, it's called invasive ductal carcinoma. So this is what we're going to talk to today. This is the ductal carcinoma in situ. And then, so atypia leads to DCIS, and DCIS leads to invasive cancer, and that's what we treated. So this is a little bit of what determines, the histological grade. And so DCIS can have different grades, and depending on the grade, it might be more different from normal tissue. And that means that it can be a little bit more aggressive and sort of like how it behaves. So the lowest grade is going to be grade 1, it's going to be low, and the highest grade is going to be 3, and it's high. And those grades are going to depend on the shape of the cell, this how big they are, the chromatin, which is usually the filling of the cell, the nucleoli or the nucleus of the cell, and how are they dividing, and how their orientation. So the lowest the grade is, that means that it's more similar to normal breast tissue. And the highest it is, it means that it's more different than the normal breast tissue, and that's how atypical this tissue looks. So a little bit of background of the DCIS is that, the incidence of DCIS increases with age. So older women will have more risk to develop DCIS. Diagnosis has increased dramatically since the improvement of mammograms and imaging in general, but mammograms specifically, because DCIS presents on mammograms as calcifications. You don't see a mass on imaging. What you see is calcifications on the breast, and that kind of like hints us that there's something going on. So yeah, as I said, presents a suspicious calcification. Then the next step is diagnostic mammography with magnified images, so we can look better at those calcifications. The mammogram, you can underestimate the extent of DCIS if there's multiple lesions or they're very large lesions that contain DCIS. And this is where MRI helps clarify the extension, but it's not really perfect. It typically, it's going to manifest as basically as a massless enhancement, or basically just enhancement on MRI without a mass, and increases, the rate of mastectomies when it's significant area that needs to be excised. But it usually has a very good prognosis, has a long-term mortality of less than 3%. So what is the rate? So we say that DCIS needs to come out because it obviously leads to invasive cancer. But what is the rate of increase in staging from non-invasive cancer, DCIS, to after we remove it and becomes invasive cancer? So after we remove it, it's usually about 4 to 30%. So that's a possibility of us taking a DCIS, and after the pathologist looked at the slides on the microscope saying, "Oh, we actually found cancer." It's in that ballpark of 4 to 30%. Nowadays, they think that the risk is actually decreasing. It's around the 15 to 20%, but that's where it is. So I'm going to give a little bit of a couple of examples to see how we deal with this DCIS. So we're going to have right now a 55-year-old postmenopausal female. Postmenopausal means that they already went through menopause. And this patient presents after they discover a 3.5 centimeter area of calcifications on a routine screening mammogram. They do a biopsy for her, and they found that she actually has a DCIS. And it has ER/PR positive, and I'll talk a little bit about the receptors later on, so we understand what the receptors are. But she has ER/PR positive and HER2 negative. So now the question is, do we do surgery for this patient? And the answer is yes. So yes, because as we said, atypia leads to DCIS, and DCIS leads to invasive cancer. And then the other thing is, when you see DCIS, there's always the risk, because when you biopsy DCIS, you're doing it with a needle, and you're only taking a piece of a larger lesion that can have invasive cancer in the surrounding area. And if you leave it alone, it's going to progress to invasive cancer. So should we operate? Yes. Now, in retrospective studies, 57,000 patients with DCIS between 1988 and 2011 did did not undergo surgery. And then what they did is that they compared, what's the 10-year survival for the patients that did go for surgery and the patients that did not go for surgery. So if we consider a very nice prognostic DCIS, which is very, very low grade, there's no real difference in 10-year survival. It's about the same, it's 98%. But if we take into account the DCIS that have a little bit more risk, then the risk of not undergoing resection is significant, having a total reduction or actually upsizing and the risk of mortality in about 6%. So we're going to continue with the same patient in our examples, and we're going to see what else we can do for this. We should do for this DCIS. So this is the same patient. She went for biopsy. She got intermediate grade DCIS, and now we're planning surgery, right? And now we come back to what are our surgical options to treat DCIS and cancer as well. So our two options are going to be a mastectomy, which is removing the whole breast, or a lumpectomy, which is removing a chunk of the breast, removing the whole area of the lesion with a rim of normal tissue around it. And I'll show you a picture of how it looks. But there haven't been like real randomized controlled trials that compare the two for DCIS. But basically comparing both and the survival in 10 years, they're very similar. Okay, so there's no real advantage in survival for either of our surgical options. And on the left, you're going to have a lumpectomy. That's what the scapula lumpectomy looks. And this is something that you might also hear as breast conserving surgery, where we just remove, the piece of the tissue that contains the cancer and with an extra layer of normal tissue around it, so we are sure that the margins are covered. And then mastectomy on the other side, where we remove the whole breast. The difference between the two in survival is the same. The difference in having local recurrence, meaning the cancer coming back in that area, is slightly higher in the lumpectomy. It's about 1 to 2% higher, and that's the reason why we do radiation afterwards, but we'll talk a little bit about that. So this same patient decided to go for a lumpectomy. So what margin do we need? And so it's different between invasive cancer and DCIS, but in DCIS, it said that we need a 2-millimeter margin. And the reasoning for this and the difference between having an invasive cancer and having a DCIS is that for invasive cancer, we only need a clear margin microscopically that the pathologist is happy about. But the DCIS, we need an actual 2-millimeter margin, so it's an even extra thick margin compared to an invasive cancer, and they may sound a little bit counterintuitive. And the reason for that is that because when we're doing surgery for DCIS, we always have in our mind that there's a risk of having invasive cancer in the surrounding area. So if we take an extra 2 millimeters of tissue around that DCIS, we're making extra sure that we're not missing an invasive cancer. But it has been demonstrated that there's no real, gain on taking any further margins than 2 millimeters. So this same lady went for the lumpectomy. Now the question is, DCIS, ductal carcinoma in situ, do we need to check on the lymph nodes? And that the way that we would check on the lymph nodes would be by doing something that we call a sentinel lymph node biopsy. And the way I'm going to explain a little bit how this works. And basically, sentinel lymph node biopsy means removing a couple lymph nodes in the axilla where usually breast cancers drain. And the way that we do is that we inject a couple markers near the tumor or near the areola or nipple, and that will travel to the lymph nodes that you usually will uptake the cancer. And that lets us, check them in the OR, and we only remove those 2 or 3 lymph nodes that are uptaking those markers. And the reason why we do this is that because in the past, for somebody that would have breast cancer, we will take all the lymph nodes in the axilla, and that showed, number one, that there was no increase in survival, and number two, that patients would get a lot of arm swelling. The risk of, getting arm swelling from doing a full nodal dissection is about 30%. That means that about 1 every 3 patients with a full axillary dissection will get significant arm swelling. And we developed this technique that has about a 4 to 6% chance of getting, well, it's actually 3 to 4% chance of getting arm swelling if we only check those select nodes. And that's the reason why we do this. Now, do we need to check lymph nodes on DCIS? And the answer is, for the most part, no. For the most part, no, because this is not invasive cancer, and we only check lymph nodes if they really have concerning features or there's a very large amount of DCIS in the breast, meaning that the extent of disease is more than 5 centimeters. There's a real associated mass, and it's not only calcifications. Or if we're planning to do a mastectomy and we're gonna disrupt those lymphatic channels that are gonna let us check for lymph nodes later if need be. Okay, so overall, sentinel lymph node biopsy is not really recommended when we're only gonna do a mastectomy for a pure DCIS. We're only gonna do that if we have a significant amount of disease or we're gonna perform a mastectomy. So this same patient that we have been talking about, she has a lumpectomy, and then the final pathology after we remove the DCIS, comes back with two small focus of microinvasion, and the closest margin is 1 millimeter. Are we gonna re-excise that? And in a different scenario, the DCIS come with some invasive cancer, and the nearest margin is 1 millimeter. Are we gonna re-excise? So we're gonna have two different answers that we're gonna talk about that. And as I said, if you only have DCIS, you need a 2 millimeter margin, and that's because we need to make sure that there's no surrounding invasive cancer. So that's if in the first micro scenario where there were two small focus of microinvasion and you only have 1 millimeter margin, yes, we need to come back and take an extra margin, make sure that there's no invasive cancer. And now you have DCIS, and at the same time you have invasive cancer, and the nearest margin is 1 millimeter. When you have invasive cancer and DCIS at the same time, we don't go by the DCIS. We take the margins needed for the invasive cancer only, and that's just negative margins for the pathologist. So we would not have to come back and take new margins. And now DCIS, do we need to do radiation for DCIS? And the answer is we should, because radiation reduces the local recurrence in about 50%. Now it is not mandatory, but it's highly suggested. Okay, and we can see here, this is the different and in survival outcomes in DCIS for all the subtypes, and we can see the difference, between patients that went with radiotherapy and without radiotherapy. The 10-year mortality is about the same, but the local recurrence is different. So if you don't do radiation, you have a small chance of that tumor coming back in the breast if you only went for a lumpectomy. If you did a mastectomy, you do not need to get radiation. So same patient, she had her lumpectomy and then she had the radiation. Does she need any more treatment? Does she need chemotherapy? Does she need endocrine therapy? So overall, patients with DCIS do not need chemotherapy, but this is when we're going to talk about the receptors of the cancer, or the receptors of the cells of the cancer in this case. And as I said before, the receptors that usually breast cancer have or could potentially have or not have is estrogen receptor, progesterone receptor. That means that the tumor or the DCIS is basically feeding from your hormones. And then I heard too that all the human body cells have, and it's a marker a little bit of aggressiveness. It can be positive or negative, all of them. And that will decide if you're gonna need, treatment for endocrine therapy or chemotherapy after the DCIS is removed. So if you have estrogen or progesterone receptor positive, for women that have not gone through menopause, we give some estrogen receptor blockers like tamoxifen, and that's usually for about 5 years. If you already had your menopause, then we give something that's called aromatase inhibitors like letrozole or anastrozole, and that's also for 5 years. And those will block specifically ER and PR receptors. Okay, they have a side effect profile, and we have to be, very careful about that because they can Specifically tamoxifen has been shown that they can develop and endometrial cancer in the long run, and that's something that needs to be considered because they are estrogen receptors blockers in the breast, but they actually potentiate a little bit the endometrial development in the uterus. And they're women like and also taking birth control medication, they can also increase the risk for blood clots. Now, the aromatase inhibitors are a little bit different, and the main side effects that people complain about is joint pain, and they have a significant profile of causing osteoporosis. So people that take aromatase inhibitors like anastrozole need DEXA scans at least yearly to check on the bone density. So conclusions in the medications for DCIS is that it's not going to affect the outcome either if we use aromatase inhibitors or tamoxifen in for DCIS, but it should be used because it has a significant risk decrease for future breast cancer and proliferation of any left DCIS. The side effects are different, but they can be selective in DCIS depending on the menopausal status. Now, the other receptor that we talked about is HER2. So 50% of estrogen receptor DCIS will overexpress the HER2 receptor, and this is clearly related with aggressiveness and prognosis and recurrence of the DCIS. Having a positive HER2 receptor, it's a marker of that. So if you have a HER2 positive, it may be predictive of radiotherapy resistance as well. So you're gonna treat the HER2 receptor with another extra medication that's called trastuzumab. Okay. So this is a little bit of an overview and basically to conclude the presentation, but how do we handle DCIS? So if it's focal, if it's just a small piece of DCIS, you can do just a lumpectomy or you can do a mastectomy. That's really going to depend on patient preference. If you do lumpectomy, you have to do whole breast radiation. Now, you can skip whole breast radiation in very select low risk cases. Patient that had advanced age, very low grade, small focus of DCIS, and the oncotype, which kind of like give us a little bit of some more risk information, tells us that it's a very low risk DCIS, but overall they should get radiation. Now, you can use sentinel lymph node biopsy in cases where you're going to do a mastectomy or you have a very, very large DCIS that it's more than 5 centimeters. Now, if you have a very extensive DCIS, meaning that you're going to have a lot of calcifications in your mammogram, we cannot just do a lumpectomy. We need to do a mastectomy. And always consider adjuvant systemic therapy like estrogen or hormone receptor blockers for the treatment of DCIS in estrogen receptor positive. We should use targeted therapy for HER2 receptor positive patients. And if somebody that had already a lumpectomy for DCIS plus radiotherapy has a recurrence, meaning that the cancer comes back, they should undergo a mastectomy. So that is all I have.
Thank you, Dr. Hansen. Ms. Evans, do you have any questions for Dr. Hansen?
Yes, I do. Thank you. The presentation is very good. I have a few questions.
Go
The
ahead.
first one, so the hormone blocker.
Yes.
Say if I choose mastectomy,
Mm-hmm.
then am I done after that, or I'm still candidate for?
So that's a very good question. So the hormone blockers are independent of which surgery you do, because they're also going to be risk reducing for the other breast. So at the moment you get a DCIS, you're also high risk to get a cancer on the other breast. So it doesn't matter if you go for lumpectomy or you go for mastectomy. If your tumor was positive for hormone receptors, you should be treated 5 years of hormone receptor blockers.
And okay, but we won't find out until the tumor is out, right? There's no way I know.
So we already know that the status of the receptors. Once you get the biopsy done, they already told us what the receptors are. So we already, if they're positive, we already know that you're gonna need 5 years of hormone receptor blockers after surgery. But that's after surgery when you start the medication.
Okay. Okay, and the other question is, you showed a section of how this a typical cell grows inside the duct.
Yeah.
Is that reversible, let's say by healthy lifestyle, different food, or
No,
what form?
so for the most part, it's not reversible.
Mhm.
And it's really so once you have a biopsy proven with atypia, that automatically increases your risk of getting breast cancer later on. So I mean, you can after you get surgery, there's certain lifestyle modifications that you can do to decrease your risk in the future, but usually with lifestyle modifications, it would not reverse. But things like high intake of alcohol, it actually increases the risk of breast cancer. And it's actually recommended that patients exercise for about 35 minutes daily for at least 5 days a week, so they decrease the risk of breast cancer as well.
Mhm. But that has nothing to do with like cells, those cells dies down or being replaced
No,
with new cells.
unfortunately, once you have a TPA or DCIS already, it won't reverse on its own with lifestyle modifications.
Okay. Is there any clinical trial that's known to us that could be done before the surgery or like replace the surgery?
Not at the moment. Unfortunately, we don't have clinical trials, and specifically for DIS, it had been demonstrated that the standard of care is surgery at the moment.
Mhm.
There are patients with invasive disease that get chemotherapy prior to surgery, but for DCIS, that's not the case at the moment.
Okay. Is it possible, last question, is it possible to have DCIS plus some other type of cancer within the same breast?
Yeah, absolutely. That we see multiple times that patients have invasive cancer at the same time they have DCIS, and sometimes they even have different subtypes. It's not the most common thing to have different subtypes of breast cancer, but specifically for patients that have genetic mutations at their very, very high risk of developing breast cancer, that can happen, yes.
So it is high likely to say if a patient chooses lumpectomy, it is very likely after the pathology report come out, you will have to go back again and be operated on, right?
No, not necessarily. As I said, the risk of us upstaging that DCIS diagnosis to cancer, it's in the ballpark of 20%. So, that means that it's going to be, about 2 people out of 10. So for the most part, we do surgery and we never have to come back ever again. But we definitely have to go and take that out to make sure that there's no surrounding invasive cancer, and also so that cancer doesn't progress to invasive cancer.
Okay. How likely, sorry, one more. How
By all
likely,
means, all the questions you have, that we're here to help you.
from the experience or from some statistics, for a person that got treated for one side of the breast for DCIS, let's say if it operated on and all good, how likely the other breast would have the same thing?
So it's really hard to tell an exact number, because the risk for every woman is different depending on family history, depending on how many TPS they had and biopsies, etc. But definitely, once you have DCIS in one breast, you have a little bit of an increased risk of getting a breast cancer on the contralateral side. But it's not. It's usually right around the numbers of an average risk.
Okay, it's not like a lot higher than.
No, it increases yearly, but by a small amount. That's why we don't recommend, getting contralateral surgery if you don't have an active cancer in that side, because having surgery in the contralateral side increases your risk during surgery, increases the risk of extra complications from the procedure, from anesthesia, And we don't really gain a benefit of just doing contralateral side unless you have a genetic mutation, which highly increases your risk of getting breast cancer in the contralateral side.
That's great to know. So in terms of plastic surgery, option, that's totally independent from the DCIS itself, right?
Yeah, that's completely independent from the DCIS itself. If we are gonna just do a lumpectomy, normally we don't do necessarily anything with plastics because our goal is to not get your breast cosmetically deformed. If we were to do a mastectomy, then we can involve a plastic surgeon so they can plan their reconstruction at the same time.
Got it. Okay, that's all I have.
Perfect. Thank you, Ms.
Perfect.
Evans, for coming.
Yes, thank you, Ms. Evans. We have one more webinar that's tomorrow. So that'll be the last for the month of October in our breast cancer awareness education webinar. So if you're interested, go back out to the link and get signed up, and we'll see you tomorrow.
I already signed up for it. I look forward to
Beautiful.
it.
Thank you. We'll see you tomorrow and have a great night.
Yeah,
Thank you.
thank you,
Bye.
Carol.
Thanks, Dr.
Thank you,
Hansen.
Hansen.
Bye-bye.
Bye-bye.
Bye-bye.